This chapter covers depressive disorders, but the main thing that we're going to look at is just the overall term of depression and in the process that we work through it with these patients. So we're not going to get into all the specifics in this chapter. When we think about major disorders, it's believed that depression is caused by a chemical imbalance in the brain. And the chemicals are those neurotransmitters that we spoke about earlier in the semester, and they're responsible for controlling brain activity, which includes the mood. When there's a deficiency in some of these chemicals, this can lead to the symptoms of depression. Some of the symptoms that we see are anhedonia, which is someone no longer taking pleasure or receiving pleasure out of activities they once enjoyed. Anergia, which is the fatigue. We'll see sleep disturbances, changes in appetites, feelings of hopelessness and worthlessness. We'll also see a lot of persistent thoughts of death or suicide, the inability to concentrate or even to make decisions, and also changes in their normal physical activity. SAD is another type of disorder that's linked to depression, and we usually see people suffering from this during the winter months. It's known as seasonal affective disorder. The month that is mainly we see this is January, because January has the least amount of sunlight. However, it can last throughout the winter months. Looking at the nursing process, when we're assessing, one first thing you want to do is assess for any type of suicidal ideations. That is vitally important in these patients. There are tools that are used to assess levels of depression, and some of the signs that we'll see are patients who have not been taking care of themselves. They haven't been going out. They don't even want to get dressed, bathe, brush their teeth, may not even get out of bed for days. Areas to assess for these patients are their affect. We want to look at their thought processes, especially those thought processes of harming themselves, their mood, feelings, their physical behavior, communication, and we even want to look at their religious beliefs and spirituality as well. Some of the negative signs of depression that would be assessed include alterations in sleep. Often a patient is going to experience difficulty sleeping or can have some type of hypersomnia. Patients also experience alterations in their appetite. Very frequently they'll have anorexia, so they may experience weight loss. Another issue is constipation, which is another one of those signs of depression. Other signs and symptoms, again, can include the anergia, anhedonia, hopelessness, suicidal ideations, and loss of attachments as well. Here's a list of nursing diagnoses, and as you can see, the priority is safety, so risk for suicide. There is also that risk for hopelessness or hopelessness diagnosis, ineffective coping, social isolation, spiritual distress, and self-care deficit. When we want to look at outcomes, you want to think about a model of recovery. So what we want to do is help them to focus on their strengths, not what they haven't accomplished or what has gotten them down or anything negative, but what are their strengths? What is it about them? Treatment goals need to be developed between you and that patient. So we don't want to do it for them, but they need to be included just like any other patient. And then we want to also base it on their personal needs and values. In other words, you don't want to set outcomes for something that they don't even hold a value for, or they're not going to even try or look forward to even trying to meet that goal. They're just going to give up or just sit there. So when we're making our plans, again, you want to think about what phase of depression are they in. Are they in the beginning phases? Is it soon, or are they in the midst of it, or are we in that maintenance coming out of that depressive state? Look at the particular symptoms. So when we're making our plan, if they're not bathing, the patient will bathe, in so many days, or, or at least tomorrow, or today. And so think about their symptoms, and then what are their personal goals. So we're making those plans. Remember to make sure it's something that can be evaluated. I spoke about the phases of depression in the beginning phase, which is also known as the acute phase. This is 6 to 12 weeks. Continuation, again, that 4 to 9, and maintenance phase is 1 year or more. So again, we want to, when we're looking at them and treating them, we want to see where they are as far as these phases. One of the keys is communication and counseling, having someone to talk to and opening up those lines of communication. Sometimes depression is all bottled up within, and they can actually get themselves depressed because they don't talk to anyone. And also teaching them how to take care of their health. Good teaching about things that they could do to get out of this rut, things that can help them, resources in the community, how to prevent relapses, such as taking their medications, not stopping their meds immediately, realizing that it may take a while for the medication to take effect. Also promoting self-care activities, getting them out, getting them to get dressed, get out of the bed, maybe even clean their house, open up the windows, open up the shades, all those types of things, even though that's not personal care, but it can affect their personal care. And teamwork and safety, again, ask those questions about, do they have those thoughts of harming themselves? Are they having those thoughts of death? Are they preoccupied with it? And also working together as a team, with the family, with them, and also with the staff that has been taking care of this individual. When we look at some of the medications, antidepressants are the front and center line of therapy, and the one we look at are SSRIs. And remember, that's with the serotonin, and we're going to inhibit the reuptake of the serotonin to make sure we have plenty. Remember, that's the happy neurotransmitter. You want to make sure you go through and you review the drugs that you were given, and look at how they work and which neurotransmitters. And I've given you a little cheat sheet here on these slides of things that I want to make sure that you look at when you're looking up your drugs. When you're with your SSRIs, again, you want to think about the patient and family teaching that should also include any reports of suicidal thoughts. This can worsen at the beginning when they begin a drug regimen, and the patient would maybe require some close monitoring during this period until the medication takes effect. With your SSRIs, it can take 1 to 3 weeks before there's actually a relief of symptoms that can be seen. And sometimes people may give up, say, oh, this isn't going to help me, I'm never going to get better, or I'm already on these drugs and I'm still not getting better, life's not worth living, or whatever the case may be with that individual. So again, making sure that you do that teaching. What I want you to do for your test is that I will give you a medication, and I will also mention what classification it is, so that will help you to have a better understanding while you're learning your medications. The tricyclic antidepressants, or your TCAs, again, you want to think about what neurotransmitter effects, when do we need to take this, adverse effects, and so forth, just like on the other slide. And one of the things that you want to remember about the side effects of these antidepressants is that they do have an anticholinergic effect. So we do have to pay attention and do a lot of teaching, because they may have urinary retention, blurred vision, nasal congestion, dry mouth, constipation. So we have to make sure that they are taking in their fluids. However, we do have to be careful, because the urinary retention can actually lead into worse things. So of course that would be a high concern of this of one of these side effects, but also too the constipation, especially if it becomes severe as well. And then we have the MAOIs. And again, you want to think about your neurotransmitters, indications, and so forth. The other thing that you want to make sure that you always give instructions, especially these, and make sure that the instructions are given to them in writing and handed off. That way they have something to refer to. Always include the family members or significant others too, to help them to supervise their medications while at home. The reason this is important is that we need to teach these patients taking the MOI antidepressants that over-the-counter medications that contain a vasopressor agent, and also that foods that have tyramine, they need to be avoided because they can precipitate a hypertensive crisis. So we need to teach them to make sure they speak with the pharmacist to see if a cold or allergy medication contains the ephedrine or the, make sure I pronounce this right, phenylpropanolamine in it, which can cause this hypertensive crisis. Also, too, remember the foods that contain the tyramine can also cause this hypertensive crisis, which is really a dangerously high blood pressure. There's a couple other types of treatments for depression, and they mentioned some of these in your book. Two of the ones I want to talk about was ECT, light therapy, St. John's Wort, and exercise. ECT. There's always been a lot of misconceptions about ECT. A lot of us have seen the movie with One Flew Over the Cuckoo's Nest. And I do have a video for you to look at on your PowerPoint slide about ECT therapy. Anyway, how it can greatly improve our patients. For many people, the name makes us think that they're going to be overly restrained and have a full seizure. It actually has become more improved, and more paralytic and anesthetic agents have actually caused this to be a less traumatic experience. Although medication is usually the first line of treatment for depression, there have been studies to indicate that patients achieve a higher rate of remission with ECT than just the antidepressants. ECT may be the preferred treatment in patients with, especially those with suicidal or homicidal thoughts, and those with psychotic or hallucination symptoms, and in cases where medication has failed. The patients receiving ECT need support with their physiological stability immediately following the treatment, because they're recovering from anesthesia, just like any other patient receiving that medication of anesthesia. It's not unusual for patients to present with recent memory impairments and or confusion during and for a short time after the ECT, so they shouldn't be making any major decisions after treatments. Light therapy is helpful for those especially with SAD, the seasonal affective disorder. And then St. John's Wort. St. John's Wort is actually an herb that's been unregulated. It's not FDA approved, but it can help be more effective with cases of mild depression. Since it is unregulated, quality control varies, and so the exact dosing and the quality of the drug can be questioned. Because St. John's Wort essentially works on the body in the same way as antidepressants, it can have a cumulative effect with antidepressants. So a lot of expert resources are cautioning against combining it with other antidepressants. In other words, you'd be over-medicating yourself. And then the other is exercise. Whether it's just going for a walk, if you like to skate, go skate. I don't suggest getting on a skateboard, but getting out, hiking, just getting moving and moving the muscles and getting everything flowing again in the body can be very therapeutic and can be very helpful. Just something as simple as that in the early stages, or if it's a milder form of depression. In the end, you want to evaluating for those thoughts of suicide. Are they still having them? Evaluate, are they eating and drinking? Are they sleeping? Are they getting enough sleep? Are they starting to take care of themselves and getting out of bed and, brushing their teeth, taking a bath, getting dressed? What is their self-esteem? Are they still like Eeyore that we saw in the earlier slide? Or, or do they still just, are they actually saying, you know what, I can do this? Are they interacting with others? Or are they still locked up in their home or in their bedroom and not talking to anyone, not answering the phone, not answering texts, not even, not doing social media? So we want to see where they are. And so the best way to do that is through our evaluation process. Okay, that's all I have.